I'll shoot on ahead with a very important topic for geriatric patients, which is essentially managing fracture hips. Now, fracture hip treatment has been revolutionized, and I would say the UK has spearheaded the way for the world with really good data on how a very organized management of fracture neck or femur can actually give you very good results. This has, of course, been largely possible by because of the NHS. And I would say one of the most important achievements of the NHS in its 6 or 7 decades of existence. I'm sure Mr. Ramandega would agree. Now, my colleague Srikanth has spoken about arthritis, joint replacements in the elderly. What I'm going to do is just try and focus on this aspect of hip fracture management in the elderly. So the hip fractures in the elderly are essentially pathological fractures because they happen because of osteoporosis. And it is a question of whether we are treating them as pathological fractures or looking at it as another fracture to deal with. So there's no doubt that it is also a fracture of necessity. There's no doubt that an intracapsular fracture especially cannot be managed conservatively. And we know that early mobilization will lead to problems. Now, that disturbance on the left is just to drive home the fact that, it is treated with very, very well accepted methods that we've known for ages. But there are things which we are probably not yet evaluating as a community worldwide in terms of morbidity. So even with the development we have of fast tracking of fracture neck femur, are we actually seeing a lot on survival and morbidity associated? What we have is survival data. We don't have morbidity data with the various techniques and options we have of treatment. Anyway, so as I stated before, the fracture neck of femur guidelines were put forward by the NHS, and of course,
Yogeesh, you there?
Yeah, very well. Are you not hearing me?
We can hear you.
Can hear you now. Go ahead.
Okay, great. Thank you. So in the UK, treatment has been fast-tracked, which leads to early rehabilitation. Now, there are different regions for which different treatments are described in a proximal femur fracture, but I am restricting this talk to arthroplasty, whether it is hemi or total, which is possible for those fractures, particularly the subcapital, transcervical, intracapsular, or even the, in a limited number of extracapsular ones, where you can get early mobilization. Now, the question of what hemiarthroplasty, if it is hemiarthroplasty, is out there to debate, but there is enough data to suggest that Austin Moore is not the thing to do any longer. And when you're doing hemiarthroplasty, bipolar does not have too much of survival and literature support to it. So the debate really, when you're doing arthroplasty, is whether you do a total hip or you do a hemiarthroplasty. I would fervently argue that if you're doing a hemiarthroplasty, there's no need to do any bipolar, though if you see, we don't have very good statistics across India, but again, the usage of bipolar far exceeds that of unipolar hemiarthroplasty in our country. There's no doubt about it. The debate can continue as to when and why to do a total hip, but we are restricting our talk here to using cement. So what appears from far as attractive may not be as so when you look at it in the entire perspective. So when you talk about hemiarthroplasties, there's of course a collared unipolar hemiarthroplasties. I'm going to go and classify these. This is a Thompson's prosthesis with cement, which has been criticized, particularly because of its bend and that beak, which can cause fracture in the shaft of the femur. It's not very well designed for the femoral shape. But what is still very commonly used and certainly should not, though it is still being used probably just because of a cost factor, is this particular prosthesis, which may be revolutionized and managed to survive because of its success in the Second World War. But we have moved far ahead. We have good enough recommendations that, that will not survive if somebody mobilizes in it regularly for more than a couple of years. So when it comes to a cemented stem, the actual options we've got are the Charnley type of stem, or what you have, a cantilever beam, as against a tapered polished stem, which has an entirely different principle of action. Now, these are the only two prototypes of a cemented femoral stem. And probably the one on the right is definitely the best surviving femoral stem in the world out of any stems used for a total hip replacement. Having said that, it is not the stem or the brand which matters. It is the technique of cementing which is important. Overall, whether you do Exeter cementing or a Charnley type of cementing, that is, a cantilever stem or a canal filling stem, it is what I'm talking about here is try, and I think I would sufficiently convince or prove that a cemented technique is by far safer in these osteoporotic people than doing femoral stems without the use of cement. So what we've got is, in older patients, the use of cementless prosthesis was put across because of the scare of cement disease. There's enough data to show that the actual cement disease, though we might have all experienced or heard of something in our neighborhood, the actual cement disease, which can be properly associated to intraoperative death in a patient, occurs in 1 in 10,000 of your patients. Whereas there is, with those references and many more, with cementless arthroplasty, which is by far becoming a lot commoner around the world, different studies have quoted periprosthetic fractures with the use of cementless stems, particularly in proximal fracture femur in elderly patients, from rates of 7 to 13%. Now, here is the exact paradigm, because we are advocating early treatment and early mobilization in these people. And even though you might get a large number of these fractures might be type A or type B1 periprosthetic fractures, are you then really going to be able to mobilize these patients? So that is what I meant on data on early recovery and actually morbidity, which then can have far-reaching consequences in this very, very fragile group of patients we are treating. The key here, if you are using cementless prosthesis, is to get a right entry point, have a right broach, and not bang in the broach in a cementless prosthesis, rather test rotational stability. So if you are using a cementless prosthesis in a hemi or a total hip replacement, whatever it is, in a fracture neck femur, I would say you would have more experience required than you need for a cemented. Problem in our country is, even though the Exeter design is well documented to be successful, we don't follow or have facilities to do third generation cementing in every orthopedic setup, or even in most of our medical colleges. I would therefore advocate that if you are using cement without the Exeter technique, don't be a blind follower of the Exeter stem or the Exeter prototype of stem. 80% of people who make Exeter prototypes do not have the facilities to provide you with third generation cementing techniques. So it won't work if it is not used with the proper pressurization. Hence, you would be able to do a much cheaper method of a hemiarthroplasty with a Mueller type stem using a second generation cementing, which will still have a much longer survival in these patients. Now, there is, again, just to quote data, there are good guidelines about what prosthesis to use, recommendations for not using Austin Moore or Thompson's, and approach as well, because anterolateral approach is documented in the larger series to have a less dislocation rate. But that's besides the point of discussion here. What I want to show is cementless prosthesis. Patients who really walk on them will probably not end up using or being able to use these prostheses for a long time. So I will end up probably with a few examples here. So here is a cementless design of a hemiarthroplasty, which you see has got a severe protrusio. Now, that luckily, I had a chat with the primary surgeon who did this, and that happened in about 4 years of usage in a relatively young patient. Clearly not a good indication to do, which would have been, if it was a young patient who was active, that would have been an indication for a total hip replacement. Now, this patient was cash strapped. Now, again, what I have done here is, because we don't have expensive options, I have used an Indian make of a cementless rigid stem, but with an ETO, you can use a rigid stem, and I have used it like a canal filling stem with cement. And also what I've done is used cement with pressure with bone grafting, which is again well documented for the acetabular side. And, just to show the whole prosthesis here, with that grafting of the protrusio can survive well. It has been very well documented for a longer term survival. That will come at a cost to the patient of something like 50 to 60,000 rupees, which would be a similar cost of prosthesis when you're doing a modular cementless bipolar in these patients anyways. And that is the cost of a revision. So similar case, another one here, of course, if somebody has more money and a younger patient, you could probably build up and have better bone stock. That is a better option if you have more access to finances for revising these sorts of cases. Now, another one here, a cementless design, quite a poor design, because it is relying precisely on just a metaphyseal fit here with no fit lower down. There are better designs of cementless stems with curved stems, which would probably do well if the surgeon has to select a cementless design. But here you can see the surgeon has probably caused an intraoperative fracture there, and again the tip there, which because of a not very good entry point has resulted in a varus and an impending fracture there distally as well. So similarly, that can be revised with a hybrid kind of design, depending on, it's always money which decides many times what choice of prosthesis we have. Again, another example of a good preserved distal cortex, only with some acetabulum related minor protrusio, which has been filled up with a bone graft and a cementless technique, still could use a short stem. Of course, to do a short stem, I would see the entire cortex and get a full length femur X-ray and take it from there. Now, the advantage here was a hemiarthroplasty which failed because of heterotopic ossification. The surgeon had probably had, unfortunately don't have the pre-op X-ray here, the surgeon had probably had a trochanteric fracture intraoperatively, but the stem was cemented and it was a hemiarthroplasty. The patient then developed heterotopic ossification. I had to revise it with trying to cause minimal damage to the trochanter because the abductor mechanism wasn't very great. But when I revised that, I could revise it with a cement and cement revision. So much easier for younger patients to revise a cemented stem again if the distal cortex is okay and some reasonable amount of cementing has been done. That was the only message I had to put from that slide. Thank you very much for a patient listening. And it was again a privilege to present here. Thank you very much.